So Phil, one test that was being used quite a bit, and I think it's off the registry now, is sodium fluoride PET.
Correct.
So where do we stand with that? Because I thought the NOPAR registry ended for that recently, correct?
You're absolutely right. So the NOPAR registry has been in effect for the past 3 or 4 years, collected data, reported some of the data that showed an increase in change in management in those patients who received sodium fluoride PET-CT. However, CMS did not accept that as enough evidence for approval. They did decide to extend the registry for another 2 years, and that recently closed in December of 2017. So the registry is now closed, and from what I know, there's no plans to extend that registry. So in my opinion, I don't think we'll be seeing reimbursement from CMS for sodium fluoride PET-CT.
What was the strength of sodium fluoride PET?
You know, there are some strengths and there are a lot of weaknesses. I think the strengths were the fact that it was sort of a bone scan on steroids. It detected bony disease much better than anything we've done in the past. And you combine it with a CT, which helped you increase the specificity. Because now you had a CT that could tell you exactly whether it was degenerative disease or something else that was causing the activity rather than a bone met. I think the limitations were the fact that in the community and just overall, there were a lot of false positives. I think that was a concern. Despite what the literature says, I think in real practice there are a lot of false positives. Number two, a limitation is it only images the bone, which the newer next generation imaging tools image bone and soft tissues better than sodium fluoride did in the past. And the third limitation is the fact that sodium fluoride PET-CT images the bony response to disease, not the disease itself. So this idea of flare still exists. So I think for those 3 reasons, it probably makes sense for us to move forward and really embrace the flucyclovines, the PSMAs, and the other tools that we have coming down the pike.
But my understanding is that the flucyclovine, there's not been a lot of work done by the company in this CRPC population, correct?
Correct. And when we look at the CRPC space, we created radar for the M0 CRPC patients. And that was because there was an unmet need in that area. And we're going to talk about this for M0 CRPC patients, but now that there are some therapies that we could be using, what is really the value of imaging in this setting? And I don't really think we've established that. So in my opinion, an imaging test needs to be safe and accurate, and then it needs to produce actionable results. And now if we have therapies that we could be using for these patients that provide a clinical benefit and value to our patients, why do we need imaging to change that paradigm? Again, we need to make decisions based on the available data, and we have no available data that tells us that advanced imaging in this M0 CRPC population will lead to better outcomes.